Good afternoon. We're going to get started on the next session. We have a couple live cases. I'm Lawrence Garcia out of Boston. My co-moderator is John Laird out of Napa in California. We have a very distinguished series of panelists. And I've been told that we're going to start over in Seoul National University with Dr. Yoon.
Hello.
Hey, Dr. Yoon, can you hear us okay, sir?
Good afternoon, ladies and gentlemen. This is Seoul National University Bundang Hospital. My name is Chang-Hwan, working at here. And on my right, Dr. Kim, could you introduce yourself?
Hello, I am Do-Hyun Kim, and I'm a first-year fellow at the Department of Cardiology, Seoul National University of Bundang Hospital. Nice to meet you guys.
Okay, today we are preparing a common iliac artery occlusion case. It looks simple, but I already started this patient, but it doesn't look simple. But anyway, let me start this case. Dr. Kim, could you introduce our case?
Okay, I will present you the live case number 3. Briefly, the patient is male, 59 years old male, and he was suffering from right leg claudication, about Rutherford grade 1, category 2. He had past medical history of diabetes, hypertension, and dyslipidemia. Next, please. And he was an ex-smoker and quit smoking 15 years ago. So under the impression of right lower extremity peripheral arterial occlusive disease, we planned to perform diagnostic workup. Next, please. The thoracic echocardiography showed severe LV systolic dysfunction, about ejection fraction about 26%, and combined mild LV dysfunction and global hypokinesia. And ankle brachial index showed 0.65 and 1.01, right and left respectively. Next, please. And the CT angiography of lower extremity showed right common iliac artery segmental near total occlusion, and average house field unit of the occlusion was 74.7. Next, please. He's taking ARNI, concaravate beta blocker, and mineralocorticoid receptor antagonist, and SGLT2 inhibitor, and statin as heart failure with reduced ejection fraction, and he's also taking clopidogrel as adjunctive medication. So today we're planning to perform PTA to the right common iliac artery. Next, please. And before we start, we'd like to discuss about several things. First, we want to talk about the optimal approach route between crossover or retrograde. And next, which would be the best guide wire? And also, how can we protect the patient from the distal thromboembolism? And which would be the best revascularization modality among stent graft and balloon angioplasty? And also, which would be the optimal landing zone for the bifurcation lesion? That brings me to my presentation. Thank you for your attention.
Okay, for the detail, we would like to show the CT angiography. Could you show up the CT angiography? Okay. This is a common iliac artery occlusion, which have proximal stump around 1 or 2 centimeter. And then there is also distal bifurcation are saved. The external iliac artery and internal iliac artery have the same orifice. So this is very short common iliac artery region. I measured the region length. It is about 3 centimeter, and the proximal and distal reference vessel is 10 millimeter diameter. So could you discuss which approach is best for this patient?
I'm Dr. Chung-Ho from Taiwan, but before the discussion, I want to ask about one thing, because we always say when you're going to do a iliac intervention, you're handy you must have a graft stent to prevent vessel rupture. But I know the Viabang, you don't have the Viabang here, so what's the substitute? And is it easy to use or profile larger than Viabang, or maybe even more easy to use?
So except we don't have Biovan stent graft here, but we have live stream graft, balloon expandable graft stent. So if there is a rupture case during our procedure, we can prevent more bleeding with this graft stent.
So if you have two stents, which one do you want to use? I just want to know the difference.
No, we don't have the Biovan. We have live stream balloon expandable graft stent. So but the maximum size is limited. So our practice is pre-dilate the region with smaller balloon, and if there is a rupture or something else, we put the live stream.
So this is a very interesting case. Did you tell me just how long the patient has been having claudication? Is this something that's relatively acute, or is it long-term?
So this is long-term claudication patient. This patient consulted to the neurologist because of the leg pain and the paresthesia, something like that. And the neurologist referred to us because of the vessel, the ABI abnormality. So he visited this neurologist frequently, maybe 6 months ago. So this is not the acute case.
So given that, John, do you have any particular thoughts of your general approach here? Would it be retrograde? There's a beak on that side, and there's the crossover technique. There's also a nice nubbin at the common.
Well, these are the best cases, right? I mean,
Right.
These are the cases that we live for, a chronic occlusion of one of the iliac arteries, because usually we're successful. Generally, they're safe procedures. The outcomes are great. Patients feel dramatically better, and these are durable procedures. I think the literature would suggest, and experience would suggest, if you can cross from above, you probably have a little bit better chance of staying intraluminal. And so since we have a nice kind of beak there, I would probably try to cross from above. This is a case that could have also been done very readily from the radial artery, radial to peripheral approach, and you might get better purchase of your catheter in that stump from above from a radial approach, but could also be done quite readily from a contralateral approach. So I would probably try contralateral approach first or a radial approach, and then if that fails, then try to cross from below. I personally don't think that distal embolic protection is required in a chronic occlusion like this because the risk of distal embolization is quite low.
And then your stent of choice?
I think that you could make a case that a covered stent, just in general, is a good option for a case like this, but I think a good balloon expandable stent with well-sized, either by angiography or IVUS, will also give good results.
Outstanding. Anybody else on the panel have a different
But I have
thought?
a different opinion here because anyway, after the successful wiring, you need to place a stent from right femoral artery, right? Because the lesion is so close to the bifurcation. So why just try maybe contralateral? If it fails, just puncture the right common femoral artery because the shape here is maybe not very difficult to penetrate. If ILO fails, I will choose left brachial radial.
Dr. Yoon, what is your approach here?
So today, first of all, I would like to show you the integrated approach. We take the coronary angiography because of the LV dysfunction. We would like to find the coronary disease might be the cause of the LV dysfunction, but the coronary shows only small vessel stenosis, and then his echocardiography showed the global hypokinesia. So this ischemic region is not the cause of his LV dysfunction. So I decided to continue the medication and see if his LV function is improving or not. And then today we are going to proceed this procedure. And this is first angiography. PSA. You can find the proximal stump is very cut off like the stump. And then you can find the distal stump at the bifurcation level. And then based on the CT finding and this finding, I think this region is not tough, and then maybe there is some micro vessels inside. So I decided to approach the antegrade. I just touched the proximal region to feel the how thick is that, and then this 035 wire cannot pass freely. If there is some thrombus, this wire can easily pass the region, and then if so, the situation is totally changed to thrombotic region. So, but it doesn't penetrate it. And I frequently choose this Omni catheter, and inside the Omni catheter, I insert the 018 wire with support of a CXI catheter. And using this one, I can usually penetrate the proximal stump like this. I advance the CXI catheter, and I can check the process with this contralateral angiography. You can find the CXI and wire is penetrating into the lesion, but it doesn't. It's very tough lesion. It is not thrombotic lesion, so this was stuck in the middle. And then I push the wire and make a small loop and advanced. The loop technique guarantee the wire is inside the vessel. If I use this gladius wire, 3 gram tip rod, and then I advanced the CXI, and then I think the loop touched the distal stump, and I check the angiography here. You can find the distal part of the wire touch the proximal stump, and I would like to penetrate the distal cap. So I changed the wire to Astato 20 014 wire, hoping that the wire can penetrate the lumen well. But the disadvantage of this Omni catheter is there is a proximal loop of the catheter that makes the wire navigation harder. So I cannot navigate the wire tip, and then this isn't in the true lumen. So I think the more procedure can be dangerous to the patient.
Do we have other projection like lateral view?
Yes, this is the other projection and the other direction of the wire, and then this wire absolutely off the target.
Yeah, the risk now is if you create a dissection from above and re-enter distally, you could close off the internal iliac. So I think at this point in time, given what you have, I would convert to attempt a retrograde crossing of the lesion. The other thing is the angiogram demonstrates a little bit more disease in the left common iliac than I appreciated on the CT scan. So I think kissing stents will be required to treat adequately both common iliac arteries. So you will need retrograde access from the right side anyway. So I would make the switch at this point.
Regarding the left common iliac artery lesion, the ABI showed over 0.9, and then we already tested the exercise ABI test, and then it showed no more decrease in the left limb. Instead, the right limb showed 0.23 ABI during exercise. So I think the right region is only the significant lesion today.
Yeah,
Anyway,
just a
thanks
question
for
of
your
whether when you
comment.
stent the right side, whether you're going to shift plaque to the left side,
Yes.
particularly given the moderate disease that's present there. So
But-
I would be prepared to treat the left as well.
But it certainly demonstrates this idea that short lesions still are very difficult sometimes, even in
Yes.
with good technique, that you can still get into the subintimal plane, which is sometimes unfortunate. But that other projection really does show you how it looks in the AP view, like you're right on it, but you were off by quite a bit. And so to progress there, as Dr. Laird was saying, it becomes a big challenge that you could make things a lot worse. So the challenge now with the retrograde is that you need to be able to enter centrally. If this goes awry, then I guess the options are going to be kind of a rendezvous technique without creating much of a bigger complication.
Dr. Yoon, this kind of region, the region is located near the ostium of common iliac. So precise stenting can be done by a retrograde ipsilateral approach. So you definitely need a retrograde approach initially. So you have to do a bidirectional. The second thing is a transradial approach is better than contraradial transfemoral for this kind of situation, because perpendicular plane is easier to manipulate guide wire from the transradial. So the first one thing, common iliac ostial region, maybe transradial is better. The second is initial bidirectional puncture should be needed to reduce CTO segment extension.
Yeah, thank you for a good comment, Dr. Lee. If there is some stump proximally, I sometimes use the radial approach, but usually I use this contralateral approach because to insert the stent, we need bigger than 7 French sheaths, and through the radial approach, it's not easy to use the 7 French sheaths, and then also
7 French is needed. It's later retrograde sheath for the
yes,
stenting.
of
So
course.
not
So if
radial.
I-
Radial is 5 French is not enough.
If I use the ipsilateral approach, the proximal, the contralateral wire is just only the guide of the ipsilateral retrograde approach. So there is no need of radial approach in the case. So that's why I just make the procedure simple. And radial approach is also simple, but it's long. So I prefer the right contralateral approach if there is a still small stump inside. Anyway, as Dr. Garcia pointed, this is a critical point. So I chose the ipsilateral puncture using the angiography guidance. As you can see here, the puncture moment. I can touch the femoral artery, common femoral artery. And then I progress the wire from retrogradely. And then I inserted the wire bluntly first, and then it looks progressed to the proximal lesion with the support of a CXI catheter. And this there was a pre-motion of the wire at this point, but the wire goes different plane. It looks inside the vessel, but if I progress the wire more, it goes outside. So I push back the wire again, and then I redirect the retrograde wire. And this is, you can find, this is a different angle and entry point. And then I change the wire to the gladius, and then I make the loop of loop again. And here, this is the end of my previous procedure, and then I will show you the current state. You saw that there is a jumping up moment of the wire and then CXI catheter. And I hope this is inside the vessel. And now I progress the wire, but this is not inside the vessel.
By the way, when you introduce the case, you mentioned about your toolbox, but I don't see any re-entrant device. So do you have maybe out back or go back, any kind of re-entry device, maybe?
Usually I don't use a re-entry device during common iliac artery procedure because I think it can increase the operation risk. So instead I just bilateral approach and then rendezvous technique to make in the subintimal space. And then if I fail in this situation, and then I will try the reverse cut technique, and then I will finalize the procedure. Anyway, here I can navigate the retrograde wire in the proximity of the proximal cap. So now I change the wire to the astato again to enhance the navigation ability.
Yeah, I have to say this would be a perfect case for a reentry device, Pioneer Plus 6 French compatible IVUS guided reentry. This is a perfect kind of case because you have a nice proximal stump in the common iliac artery to puncture back into. You don't have to puncture into the aorta. I've done a ton of the cases. It's always the perfect bailout when you get into a situation like this. You can easily turn it into a successful case.
Yeah,
So
and the
that's a-
throw is 11 millimeters, right, on the outback, as is the Pioneer.
12 millimeters,
12.
yeah. But yeah, this would be a good case for Pioneer. It's very safe, and so it would be an option if you had that available in Korea.
Yeah, good idea. But we don't have the Pioneer reentry devices until now, as far as I know.
What about IVUS? They do that in Japan quite a bit to follow their path north for the rendezvous. Sensei?
Yes, thank you. So I think the IVUS is a good candidate for the assess the wire location. Maybe the wire, retrograde wire through the subintimal space, and we can confirm the wire location from the antegrade portion. Maybe this CTO wire easily pass through the subintimal space because you make a subintimal loop, making a loop. That's why I strongly use the IVUS to confirm the wire from the antegrade approach. This is a common situation in iliac revascularization. Thank you.
Osamu, what would be your guide wire of choice to try and cross this CTO from the beginning? What would you use?
It's up to the severity of the calcification, but basically I prefer the Gradius 3-gram wire first. After that, the Trezor or start. But the target is very simple. I personally use the Astat to penetrate the cap.
You like the Astato 30 gram, like 18 thousandths wire? Or?
I love 14 Astat.
I've had great success with the 30 gram, 18 thousandths Astato wire for these cases.
It gives you a little bit more directional push. Because I think that most of us know, I mean, the amount of tissue when you go subintimal in the aortoiliac is really pretty generous. And so it depends on how deep you are to be able to pop back into the to the lumen. That's where the reentry catheters are so useful.
So I usually target the proximal wire using multiplanar projection, but this wire is a little bit broken, so it's not easy to navigate the tip exactly. So I changed the wire up to 018 Astato, which has a 30 gram tip load.
Because the wire is at least much closer than last moment, so I don't know when is the moment we can use a cut or reverse cut, and which one is better.
Yeah, it is also a good option.
I think that this retrograde wire is located in the subintimal space, maybe from the middle part of the CTO, maybe. So at this moment, you can use integrated approach again with the directional control rubber guide wire such as Halberd or Astato with a wire marker technique If it's unsuccessful, you may consider a little bit, integrate guide wires a little bit advanced. You can do a retrograde directional control of retrograde wires, so meet together inside of CTO. If it's unsuccessful, you may apply IBUS evaluation where the wire location.
Okay, just 3 minutes. Give me 3 minutes, and then I will change the reverse card. Test.
Does anybody
And
feel
then
that the
right,
antegrade
rail.
catheter would be better with like a IMA or something like that as a guide to give you a little bit more support from the mod hook?
Maybe this case, IMA catheter seems to be better.
So, but because
Hello?
the loop of the guiding is so strange, so I just wonder if we just pull back the guiding a little bit, the head of the guiding caster will slide into the contralateral side, or maybe prolapse.
Dr. Yoon, in my case, my name is Cheol, Busan National. In my cases, I prefer to the radial and brachial approach to make the large spotting power, big spotting power, and then to reduce the procedure time. So most of retrograde approach lie in the pulse lumen.
Dr. Yoon, maybe the retrograde wire is already located in the suboptimal.
Yes, you are right.
From the
I
CTO
will-
segment, so you have
I
to
will
do
make
integrate
the
navigation again.
integrated navigation.
Yeah, then if you fail, maybe I will start.
And then in the case, is contralateral approach is less small spotting power. So
이거를 아스타토를 이쪽으로 주고 out. I remain this astato wire inside the vessel, and then I'll try integrate approach through the catheter again.
And then with the presumption that you're going to rendezvous these two wires, is there a role for IVUS at this point to see how deep you are to the adventitia before you start dilating? Is that something everybody would do, or is it just based on the pre-dill back pain?
Normally, I don't use anesthesia. The pain is a very good indicator of the serious complication. So I make the patient alert, and then I ask again and again, do you feel the pain or not? And then if there is pain, I stop the ballooning and then deflate it, and then I check the angio again. Check that. Astato.
And I just wonder who will care about the bleeding issue after cut or reverse cut, and if it happens, what can we do? Because in that kind of situation, the wire is not at a true movement, and still bleeding shock, and then what to do next? Because I have this kind of patient, but I fail the cut and reverse cut and use the double balloon, and it result in a huge traumatization. So
Yeah, that's a bad situation. That's not an easy bailout situation if that happens.
the only way to manage that kind of situation is a proximal balloon dilatation. In the severe emergency situation, distal aortic balloon dilatation, and then we are going to manage the next step.
because in the afternoon, my student presented a case. We just the wire come from above to just then the rupture hold, and then continue our work to find the Chul-Min. And very fortunately, the wire goes to the Chul-Min to complete the work.
Yeah, it's if that were to happen, as I think Dr. Laird pointed out, is probably one of the most challenging ways to get your, your case done, because there's no easy way to save that at that point. I think you're occluding the aorta at that point, and then probably going off to the OR if they're in shock.
Yes.
Which wire are you using right now?
This is Astato 014 wire.
엄니를 약간 내려서
Dr. Yoon?
컨트롤 해보세요.
So you
Yeah.
pull more down to omnicatheter for backup
Yes.
support.
Yeah.
Yes.
좀 더 당겨.
So more down.
엄니만.
Yeah, it'd be nice to get the tip of that catheter into the
The CT.
common iliac, yeah, into the occlusion.
그렇죠.
But I think this is not the center of the proximal cap.
I think
And,
more down of omnicatheter some can make a more centered wiring.
Yes.
Can make.
Thank
Yeah, there
you.
you go.
리디렉션 해보세요.
Yeah, that seems to be. There you
Yes.
For the good comments.
Okay, more down, and I think the direction can make more some exact. Okay.
Good.
Okay.
The United
it's
States,
better.
they had this thing called the Houdini catheter, which was this invaginated balloon
Okay,
that
seems to
tended
be
to
better.
draw the thing into the center of the lumen.
자, 다시 아까 018.
I think in this condition you should use more soft wire.
Yes, I'm changing wire to the gladius.
Did you use a single plane or do you have biplane system?
일단 그거 주세요.
Maybe more convenient.
And I recommend for the right side sheath was more longer sheath for some backup support for bidirectional approach. So it needed some long sheath to right common femoral.
Yeah, this is Viking sheath, so it is longer.
Right side.
No, right side,
Right
right
side.
side.
Oh, right side. Okay, okay.
Yeah.
It's too bad you don't have a Pioneer reentry catheter. You could be in your office having a cup of coffee right now, thinking about how great the case turned out.
Yes. Yeah.
Did that have any more resistance going in this time as opposed to the previous?
Yes. There is also resistance here at this moment.
I think
And I
it loop area.
navigate the proximal, the retrograde wire here.
It doesn't look like it's
그
interacting.
CXI 하나 더 주세요. 아 그리고 여기 시스 체인지하게 그 레디알 시스 좀 긴 거 하나만 주세요.
세븐 프렌치로 넣으세요, 선생님. 거기 스탠트.
예, 세븐 프렌치 레디알 시스. 레디알 시스 세븐 프렌치가 있나? 아니면 018 그 다일레이터 있는 시스 하나 주시고.
How about the loop technique at this moment and take reading?
Loop technique,
Yes,
more,
a little bit, yeah, a little bit pushy.
a little bit pushing.
Yeah.
Yes,
Yeah,
I
I
think
think
it
side to
makes
change the
the
yeah.
more dissection.
No.
I think it work.
Still.
It work?
It's a
Okay.
segment, yeah.
I will try.
Advance CXI first,
CXI first.
Yes,
then loop.
of
Pushing
course.
guide wire.
So that point.
But to make a strong support is unsafe sheath across the aortic bifurcation. Like
Oh,
this.
it's difficult.
Okay. Yes.
Difficult.
Seems to be
Yes,
difficult.
it is possible. If it is possible.
Okay.
Okay.
A little more.
A little bit more.
Okay.
Okay, I will try.
I think it seems quite difficult now. So I just
Oh,
wonder.
now it's make the dissection bigger. So
Yeah, it's the same. I
I
think
give
you're in
up
that
here.
same plane, unfortunately.
So if it is possible to maybe try the old way, the parallel
좀
wire
시스
technique
나왔어요?
from right femoral artery,
긴 거예요?
you can find another
괜찮아요. 긴거 달아요.
route to attack.
The challenge is always when you make a looped wire and push, like from below, you create a dissection plane that's then difficult to avoid. You keep going into the same plane. So it's nice to avoid a loop wire and
Unless you're real
In case like
confident in the
that.
direction, right? What do you think about this tip of this wire? I mean, it seems like it's in a different position, right?
the tip of which wire, the
The
retrograde?
antegrade wire.
Yeah.
So is your support catheter, can that follow that tip at all?
Your pardon?
For your antegrade wire, it
Oh,
just
yeah.
looks like it's in a different plane than that loop.
Yes.
I wonder if that's something you could follow with your support wire, or support catheter.
Okay. Yeah. So the retrograde wire, I am changing the sheath, bigger one, a longer one, and then I will introduce another support catheter inside. 자, sheath를 빼고 나왔죠. Now I'm changing the sheath. 빼고 천천히.
So I think it seems that everyone loves wire to close the lesion, and though we know cut and reverse cut works, but I feel everyone don't like to use bundle.
We don't want to see anything bad happen on the big screen today.
Yeah.
If you use the reverse card technique in this condition,
선생님
I
06팔로
think
바꾸고 하셔야 될 것 같아요.
네.
actually the wire was more closer to
네,
bidirectional.
CXI 주고.
마이크로 펑션 세
사이를 살살 이렇게
Something that's worked for me in
Micro
these situations when things
dilation.
starts to kind of bend at the groin is get a 4 French
0.18
catheter
나왔나?
as a support.
0.18, 아까
And lead that first, and then
0.18
unfortunately you got to
새거
change
쓴다 그랬죠?
your wire.
새거 하나만 주세요. 네. 새 걸로. 네. 0.18 글라디우스. So during the sheath insertion, the dilator was 018, but the inside the wire inside is 014. So there was kink inside the vessel. So now I had difficulty.
Yeah, it's a little
Introducing the
problematic trying to bring a sheath in over an 014 wire in the groin.
자, 잘 잡고 이렇게 팽팽하게 잡고 있어요. 뒤에 딱 잡고 있고 밀려 나가면 당기면 안 돼. 잘 보고 TV 밀려 나오면 잡고 있죠. 네, 잡고 있습니다. Now I am advancing the support catheter, CXI, and then it is approaching my side.
So I
And
think
then I will change it to the 018 wire. Okay,
Please change the V18.
018.
so I think
Very graceful.
it's quite a good learning point for young physician how to save the sheath when your wire is kinking.
So, okay, 018.
I mean, as much as this is a challenging case, and it's turning out to be even more so, this is great on your feet thinking and a great demonstration of phenomenal technique, great cath lab crew in working together.
저항이 있어? 있어?
Maybe I think the CXI cassette are kinking at the common
I
femoral
think
artery.
so. Yeah.
Yes.
You think to here.
Yeah, just pull
Yes,
back,
just
slice
maybe-
it,
back.
straighten it out.
Just here it is kink.
Slowly.
We'll watch it.
Just a moment. Outside the heart, out of the vessel, it is kinked here. 자, 천천히 넣어보세요. 들어가. 들어가지? 위에 좀 보여주세요. 계속 밀어넣어. 오케이.
Sigh of relief.
Yeah.
자, 이제 천천히 와이어 잡고 이걸 와이어 밀면서 섹스에 빼. 천천히 밀면 천천히. 저기요, 거기요.
This
Okay.
is a lot of
is out.
this is a lot of pressure for a first-year interventional cardiologist.
You may need
But Dr. Kim is very strong guy.
It's a lot of pressure for a 25-year
doesn't expire at all.
experienced cardiologist.
또 시스 드세요.
No. This moment you may need a micropuncture set to change guide wire 018 system to 035 system.
Yes, right, I think so.
You may
Change
need a
my
micropuncture set.
Yes.
Then change
Also
sheath.
Also
Don't
fine.
you-
Is sheath is 018 compatible sheath?
Yes.
Okay.
잠깐만. 오케이. It's not 018. 그 다일레이트 아까 내가 018 걸로 달라고 했잖아.
So you may need a micropuncture set to change
그
018.
radial 시스 먼저 주세요. radial 시스.
So now the Y is 08.
So we already have a radial 시스 outside.
Is
on the
that
table.
018 compatible?
Yes, it's 018
Okay.
compatible, but
Okay,
it was
right.
short, so I
No problem. Okay. At this
told
moment.
change to longer one, but the longer one was 035 compatible one.
But I
That's
think,
why
but
I
I think
didn't check the
the,
dilated tip, so that's my fault.
but I think that during the sheath insertion, you have to check the common femoral artery.
Yes, okay, that's a good idea.
But usually I will use 4 French shears, and I think it is okay to penetrate through the 018 system because micropuncture cannot shift to
Okay.
035 system. When you have a 035 system, then you can safely insert maybe 5
Now the
French.
sheath
and
is
6
safely
French.
inserted.
Okay. Thank you.
Outstanding.
Now out. 13 주세요, 13. 035 와요. 헤르모. 헤르모하고 롱 시스 집어넣을게요.
So your plan now is a 035 retrograde?
Yes, 035 retrograde, I will change the long sheath, which can approach to the distal cap. And then I'll check angio. Frequently, and then
I think the antegrade wire is at a place that I think you want to be. I'm not sure if it's any different from where we were with the loop, but sure looks like it's in line with something.
long sheath 주고. After long sheath, I will check the common femoral artery, whether there is a complication or not.
So Lawrence, assuming we get this artery opened up, what would be your preference from a stent standpoint, covered or uncovered here?
Usually, if there is
I kind of like the idea of IVUS here, just to make sure I'm not too adventitial, but I tend to agree that, or tend to believe, that I would do a stent graft from the origin down. I don't think you have to cover the internal iliac. I don't think you're going to be near it, but I think that would probably be the easiest answer. Dr. Yoon, we just left you. We're going to room 2 real quick.
일단 이거 뺄게요.
I think that I didn't
포스트 스탠팅 또 아이브스 돼야 되잖아.
just inform.
Hi, Dr. Ra. You are on the big screen. How are you?
Oh, how are you?
They transferred us pretty quick over to you. I apologize.
Okay. Are you Dr. Laird?
Yes. Good to see you, my
Good
friend.
to see you. It's my pleasure and honor to communicate with Dr. John Laird and Dr. Garcia. It's my great pleasure to share this case all of excellent panelists and the chairs and audience. Let me introduce this case. We frequently have done this case while waiting the first case. I'm Dr. Ra, working at Korea University Guru Hospital. I'm appreciate Dr. Ino Che, working at this Seoul National University. He invited me for this case. Let me introduce our team. Please.
Yeah, my name is Dr. Zhu. I work in Seoul National University Bundang Hospital.
I'm Woong-Su Yoon, a cardiology fellow at Seoul National University Bundang Hospital.
Please introduce this case.
I'll present the case. 68-year-old man with claudication was admitted for PTA. CT angiography showed multifocal atherosclerotic changes in the arteries of both lower extremities, especially segmental occlusion of the left external iliac artery and moderate to severe stenosis of the left distal superficial femoral artery. He underwent PCI for stable angina in March 2023 and has the following medical histories. Next. It was confirmed that the left external iliac artery was occluded during the CAG and PCI in March 2023. We decided to perform CT angiography and ABI test. Next. The left ABI was confirmed to be 0.52. Next. CT angiography showed long segmental occlusion of left external iliac artery and multifocal moderate to severe stenosis of left distal superficial femoral artery. So our target lesion is the left external iliac artery, and he's taking aspirin, clopidogrel, and lipid lowering agent. The teaching points include how to approach the lesion, whether adjunctive devices are necessary, and which option to choose between PTA and surgical treatment. Thank you for listening to the presentation.
Okay, thank you for the presentation. I'd like to show today's first image, angiography, and I'd like to discuss with you. Actually, this patient recently underwent PCI, the left main territory. As you saw, this March, only 1 month ago, underwent PCI left main territory stenting with 4 millimeter Cre8 stenting, only 1 month ago. So at that time, the blind, it means that they felt a pulse somewhere in the left groin. So they did left femoral puncture, but could not advance wire. So this time, the elective procedure for the left claudication. So while I'm coming here from the Walkway Hotel to here, they already took the right side puncture and the baseline pigmentary angiography. And this is today's baseline angiography in the AP view by DSA image using pigmentary 5 French catheter. Please show the baseline image. If you look at this baseline image, the common iliac artery can be seen, but the big intra-iliac artery with the later phase, you can see the distal stump in the overall architecture of the femoral head can be seen. Please run. And you can see the distal SFA near the femoral head can be seen. Upper margin of the femoral head, there is a proximal segment of the SFA can be seen. The problem is this can be challenging because we cannot clearly see the definite stump of the internal iliac and the external iliac bifurcation. So immediately after I arrived here, I took, because they didn't take the oblique view in the LAO, RAO, and the problem is also puncture is another issue. So we can do the sonoguide puncture or the fluoroscopic demarcation observing the fluoroscopic calcium, one before. Fluoroscopic calcification, negative. So just using JER4, you can see the easy demarcation of the SFA proximal. But I wanted to enough support of the short sheath for the wiring and the catheterization, so a little bit distal portion I did puncture. So next, just to show the baseline image, here is the end of the occlusion segment using the loop wire of the 3-5 sheath wire. Next, and the we should be cautious not to injure by the sheath introducer, not to break down the stump, and the gentle insertion of the sheath. Next, here is the stump of the distal. Next. So using JR, this is a baseline image. The not so long segment, however, the proximal stump is the problem.
Dr. Ra, did you do an RAO projection to see whether you can show a stump?
That's why, yes, I'm explaining the multiple different image. Next.
I thought in the AP.
This is the RAO view. Wonderful. This is the RAO view. Can you identify?
That's kind of AP view there.
Yeah.
RAO left anterior oblique. Usually this angle we can expose the possible stump, but
for a left
frankly,
iliac bifurcation, you want to do an RAO projection.
Dr. Laird, can you see the stump?
No, it looks like this view is just AP view, though, isn't it? That's 0, 0 up in the left.
This is a severe. I think that little bit very much angulated in the RAO view.
Okay.
So to identify the stump.
Can you do a very severe RAO?
Yeah.
Yeah, RAO, and next view. This is a rotating view from RAO to RAO. Still very ambiguous. RAO to RAO view.
So
in this situation, please discuss what is your strategy.
It'd be nice to see a standard DSA in the RAO just to see if there is a nipple or some form of cap from that external.
Yeah, Cheol and Panelist, what did you do for your strategy?
I tend to like to do these procedures from above whenever possible. So I would actually put a wire into the internal iliac artery, exchange for a support wire, and then bring the sheath around and park the sheath right at the distal common iliac artery, and then try to penetrate the external iliac artery with a straight wire and a catheter. And many times you can find the entry into the external iliac artery doing that technique.
Yeah, some micro channel or something.
Yeah.
And then you have this calcium that's kind of as a guide there. It seems like that's in the artery.
I think the problem from coming from below is the same problem we had in the last case, is that you can get subintimal from below, re-enter above the origin of the internal iliac artery, and then close down the internal iliac artery if you're subintimal. So could happen from either direction, but I think your chances are usually better coming from above than below in a case like this.
Okay, any other opinion from panelists?
So do we have a lateral projection? Because if your machine, if you can use true lateral, then from above you can find the external iliac go anteriorly, and if you go posteriorly, that's the wrong direction. So for my case, we always use biplane system.
Maybe after insertion of sheath from the right side through the support of internal iliac artery, left internal iliac artery, maybe usually contralateral caudal view is usually helpful with the DSA angiogram. Maybe find the osteum of the external iliac artery.
Yeah, I would try and get a sheath there, right at the distal common iliac, and then penetrate from above.
Yeah. I think if you get remember the old Balkan sheaths, but like an Ansel 3 or something would sit very nicely in that bifurcation. Even an Ansel 0 or anything straight, if you take it right to the internal bifurcation, it gives you excellent support.
How about your the wiring preference for this iliac total occlusion, the 18-wire system or the 14-CTO system?
I think it's dealer's choice at this point. I mean, I'm still kind of old school. I'd still even probe it with an 035, see if it follows a channel. many of my colleagues that go immediately to an 014 and a jacketed wire at that, or an 018 jacketed wire. I think you can, it's really,
Yeah, I have
as
to
I
say,
said,
I
dealer's
still
choice.
use 035 wires for a case like this. You know, even start with a straight Terumo wire first, just to penetrate into the cap, and then, if necessary, switch to an angled. But I've had great success with that over the years, and
Yeah.
haven't really seen a reason to change. It works very well. But you can also get, 14 or an 18 wire through here also.
Yeah, I think
Okay,
many of
shall
these
I
have
proceed?
a micro channel that you can gauge and interact with.
If the stump of left external iliac artery is ambiguous, so you can use the left femoral artery approach and then insert the wire into the left external iliac artery, and then you can use this point to indicate of a stump.
Okay, you mean the targeting, the parallel
Yes,
wiring
yes,
by
yes.
the liquid wire?
Yeah.
Okay, good. Shall I continue what we have
Please
done
tell
until
us,
writing?
tell us what you've done, Dr. Raj.
Okay, okay.
You're leaving us
Please.
in suspense here.
Yeah, this is our live. So I will show you what I have done. This is a baseline image for the SFA in case of because of some organized thrombi or some chance of distal embolization. We have to know the baseline image. So I took the baseline SFA one before. So some atherosclerotic change, but no significant lesion in the distally. Next. So initially, I used the soft J Terumo to sending wire to the end of the proximal stump. Next, but I felt that there's a difficult to deliver the catheter guiding sheath to provide the support. So I changed it to the bigger sheath is the 6 French answer check flow, and I changed it to the stiff omnicatheter, 5 French omnicatheter from Codis, and changed it to the stiff Terumo, and using this curve, delivered this natural curve of the omnicatheter, and together with this omnicatheter curve, delivered easily this answer check flow deeply into the end of a proximal stump. Next. And this is the baseline image, bi-directional image. I'm using the manual injector. And the one injection from the sheath is just the syringe sheath, syringe injection with the contrast. Still ambiguous, bi-directional image.
So your LAO there, I think REO projection again is the view to show the lesion, because you're overlapped with the internal iliac. So
this is the overlapping, multi-view.
So 30 degrees
Anyway,
REO with some caudal would be the...
Yeah, LAO, RAO, any angle overlapping. Next. So I decided to the bidirectional wiring. So the anterior sheath is waiting, like a coronary CTO technique. So I started multi-purpose 5 French supporting. I started the 18 system, the connect flex 12 gram wire from the Abbott. Next, gently, because we can see some fluoroscopic calcified vessel wall demarcation. So along with the demarcation, I'm trying to stay in the middle line and trying to navigate into the vessel wall. We can see clearly some vessel wall on the fluoroscopy in the internal iliac and the external iliac bifurcation. The next, and then this point, I can feel some branching point, but I cannot negotiate here to the intralumen. So until here, I felt the tissue itself is not so dense. So proceeded this multi-purpose catheter up to here. That means that I'm making some space along with this liquid wire, and started with the JR catheter because one before, the previous image, I could see the possible stump must be in the left side in the AP view. So I decided to not using the straight catheter like a multipurpose. I decided to use the previous JR catheter because that has the more acute angle. So next, using this JR catheter, this is good to control the angulation. So I used this parallel wire along with this retrograde wire. Next. So this is the aerial view. So using this, I tried to stay in the exactly parallel wiring along with this distal wire. Next. And I pulled back the retrograde catheter, and there's a space. So along with this space, like a small catheter in this reverse cut, the cut effect, then I sent this anterograde same connector flex wire, 12 gram. It easily entered into the distal lumen. Next. Next. This is the evidence of the anterior wires inside of the SF lumen, and removed. You can see the stump is exactly entered. Next. This is the baseline of the immediate after wiring. We removed all the endocatheter. Next. I don't want to leave this 5-inch sheath. So using during this 4-0 pre-dilation, 40 millimeter 18 balloon, during inflation of pre-dilation, I used 5 French the closure, the Codis closure system, removed the 5-inch sheath during pre-dilation. So Ming's closure, we already removed this 5-inch sheath. Next, all the pre-dilation. This is immediate after pre-dilation because the procedure was finished too early before coming to here. You coming to here, so we were very boring. So I did the IBUS while waiting here. So please show the IBUS.
IBUS is charged for you, not patient.
Because no insurance routine procedure, I don't do IBUS, but we have 18 post IBUS system here. So the main intention was to decide the stent reference diameter, and also to show my wiring is intra-plug, where it's showing the zigzag of the partly involved in the adventitia or the subintimal space or any eccentricity, the plug burden, and part of the organized thrombi, and where the presence of fresh thrombi. And please look at the thrombi nature and the chance of embolization when you do the further procedure, or any other particular characteristics of this IBUS finding. This is the IBUS finding. Can you see the IBUS finding?
Yes, it's on the screen.
Okay. This is to remove the boring of this procedure. Please discuss what I have done now.
So now that you've connected those, what is and you've pre-dilated, are you going
4 millimeter pre-dilation.
Can we see the IVUS back to the internal iliac artery? It looks like your true lumen the whole way, but just want to...
I felt it's almost intralumen. And the next stage, I'm planning to do the 6 millimeter 8. 다 pre-dilation 했던가요? And we have done, next image, while waiting, we have done the 608 millimeter pre-dilation, further pre-dilation, more aggressive pre-dilation. And next, this is the immediate after pre-dilation. And we were discussing about the stenting. So to preserve the internal iliac artery, because that is a very big branch. So self-expanding to follow this angle, self-expanding. My idea was to 6 French comparable the distal reference. I think that 10 millimeter is enough, but proximal is over 10 millimeter is more nice. However, 10 millimeter size is maximum in this lab. So anyway, I decided to 10 by 10 millimeter absolute first from distal. How about your opinion? absolute pro.
Did I hear you right? You're going to go 10 by 10?
10 by 10 first.
Yeah. It's a bit generous for that distal vessel, but
Yeah, it
I think
seems-
distal 10 is okay.
Before implementation, it's better to change the guide wire to O35 system for the safe delivery of stent.
and this is an 018 wire?
파이널 찍은 것 좀.
This is 018.
그거예요? 제일 마지막 찍은 거. Last image. Last 저 distal landing. Please show the distal stump. I think we can landing in the distal, just distal to the pelvic inlet.
Okay.
I like the idea of a self-expanding stent rather than a balloon expandable stent here, though.
Oh, for
That's
sure,
the
yeah.
best
Yeah.
answer.
I would prefer having an 035 wire as well down there. Worry about getting caught.
Well delivered.
Yeah.
Recently, we have just pending published. We have done the self-expanding versus balloon expandable iliac multi-center study. Not published, but it's almost done. But no difference between two.
Is it randomized?
We also calculated the incidence of geography miss in the iliac os, balloon expandable or self-expandable, but no difference in the expert. Here, first, because we should not miss the distal. So 여기 발른 여기 먼저 풀게요. 하고 위에 모자르면 큰 거를 하나 더 볼게요. I will slowly start from the distal.
Nice.
가장 safe.
10 centimeter is long enough.
One to one out.
Yeah, I think so. I mean, it looked like that was plenty long. Dr. Ra, after you take this, once you put your stent in and take a photo, we're going to try to head back to room 1, but maybe between then and now, Iida Sensei may be able to do his talk on critical limb ischemia.
But in fact, I have a small problem. And I think the technique is quite good, but from the beginning, the chart is so strange. So the patient is admitted for PTA. That's not the chief complaint, but there's also the problem in
That looks
Taiwan.
lovely, Dr. Ra.
So what happened to the history taking? Just my small question.
Dr.
Actually, frankly speaking,
let me see
without
RAU.
IBUS,
Let me see RAU quarter view. Once more.
Dr. Ra, we're gonna switch over to room 1 real quick, and we'll be back with you in just a few seconds, okay?
Yeah, because let me comment finally because this if I have not done the IBUS, I will not do additional studies. And unlike the coronary work, I will do the little less size, smaller size of adjuvant balloon, 8 millimeter in the distally, because always we should be very cautious in the iliac injury, not to make a perforation.
Absolutely, yeah. You
I
don't
will
want to ruin this
do the
case by
adjuvant balloon.
rupturing the
Yes.
external iliac.
Yeah, no, that's a great case,
You can change it to the another one.
Thank you, Dr. Ra.
I will final with just modification optimally.
We'll be back to see the final result. Thank you.
Nice job, Dr. Ra.
Thank you.
We can transfer now to room 1.
Hello.
Yes.
This is room 1, Dr. Yoon.
Yoon, we're back with you.
After recovery of the sheath system, I succeeded in penetrate integrated wire using reverse cut system. And then now I balloon with 5 millimeter balloon angioplasty. I would like to check the current status, just to check whether there is a complication or not. Please allow me to take this shot. 네.
Nice penetration. Would you show us previous procedures?
Okay, just a moment. It is moving, so
No problem, no problem.
Yeah. Okay. I will show you the previous procedure.
You look tired.
I think this was very simple case, and I think that I can finish it within 15 minutes. It was tough, and I had difficulty. Okay, so this was previous angio, and then after inserting the long sheath, I take this shot, and then I can find there is a distal cap narrowed portion, and I was trying to penetrate that portion, and then I can penetrate the distal wire, and then I found that there was an alignment together, anterior wire and distal wire, and I think that's the best point of the reverse cut.
At this moment, we need a rotational angiogram to confirm the
I
wire
checked
position in the same space.
Yeah, that's a good point. This is what I did. And then I checked the direction a little bit different, but when I pushed the anterior wire, I found that it is heading for the Chul-Min here. And then now I can see the anterior wire touch the retrograde wire, and then I found that this is true space, and then this looped wire is easily go to the below, as you can see here, freely go down to the vessel. So I think this is in the Chul-Min, and then I changed the anterior wire to deeply, and then this is O0 balloon angioplasty, but it cannot pass in the middle portion. It was very tight. So I changed to 2 millimeter balloon, and then I succeeded to penetrate the 5 millimeter balloon again, and then balloon angioplasty here, and that's the angiography you saw lastly. Now I try to change the guide wire with O13 and then balloon with 8 millimeter balloon.
Dr. Yoon, how about to use retrograde wiring from the right side?
Right side?
Yeah.
It can be also considered. It can be considered, but I think there is a sufficient space in the proximal part, and this is short lesion. I think antegrade wire stenting is possible if I change the wire to O3.
Yeah, if I were going to do this antegrade, which I do all the time, I would want an extra support wire, 035 wire in to round out the bifurcation and also to give you a lot of support for your sheath. And then it can be done very safely.
Extra support wire, O3 wire. Implant.
You like the supercore or something like that?
Yeah, supercore or an amplat super stiff wire.
Yeah, we have amplat 035 wire, so
it takes the bifurcation and rounds it out and makes it easier to be precise with your stent.
Exactly.
And have more control.
And this one doesn't go all the way back to the origin, so you have that.
Right.
So it's probably safer that way.
And it looks like the reentry was above the origin of the internal iliac artery, so there should be no risk of closing the internal iliac when we
But
stent.
I'm not sure. The dissection can be progressed to the external iliac artery, so
yeah.
I hope it's internal. You can save the internal iliac artery. But if after bigger balloon angioplasty, if the internal artery ostium can be dangerous to be jailed, and maybe I can rewire through the retrogradely to the proximal part. That's my strategy. JR4 아까 카테터 나왔던 거.
So in this area, I don't know what kind of stance is more feasible, balloon expandable or
the stent. So I will insert the simple bare metal self-expandable stent. I read some articles which compare the balloon expandable versus self-expandable
Because this
stent.
case is common iliac arterial stem is not so long, so contralateral self-expandable stenting is a little bit dangerous. So I recommend you to put a balloon expandable stent from the contralateral. If you put the stent from the ipsilateral, you may use both self and balloon expandable, but contralateral approach, you should use a little bit precise scan location with a balloon expandable stent.
Should. Okay. I will. Thank you. balloon expandable 10에 40.
It used to be that the Europeans used to do always self-expanding stents up at the common iliacs. And I used to always believe that balloon expandables are better there. But the data says that you can use either one.
Yeah, I do prefer balloon expandable when I'm doing contralateral stenting of the common iliac arteries, just to be as precise as possible with the back of that stent near the osteum of the common iliac. And the stiff wire helps with that too in terms of the... But you also want to have a big enough sheet that you can do injections and test while you're positioning the stent.
In fact, if it is a live demo, I prefer the self-expanding stent. If it is a daily practice, I have the courage to use balloon expandable.
이번엔 조금 더 큰 풍선을 할 거예요. 아프면 바로 얘기하세요.
balloon expandable 59는 없어요, 59?
We have 2 talks to
59
give here.
있어요? 59.
Dr. Yoon, would it be possible for us to jump to at least the first talk before the end of the session, and we'll be back with you within the next 8 to 10 minutes?
I think that makes me comfort.
He's tired of listening to us.
We're telling you exactly what to do all the time, which is wrong. The first lecture is chronic limb-threatening ischemia from Dr. Iida from Kensei Hospital. Sensei.
Okay, thank you, Chairman. Good afternoon, ladies and gentlemen. I have nothing to disclose. So maybe I have to mention these 2 trials. To be honest, I'm worried about what to do next for CLTI treatment because the result of the Basel conflict with those best CLTI trial. I briefly summarize the difference between the 2 trials. Number 1 is the average age. Average age in the Basel 2 was 5 years older than the best CLI trial. Number 2 is the endpoint. The primary endpoint of the best CLI trial was composite of the male or death, male-free survival. So definition of the male was above the amputation or measuring intervention, not including the repeat endovascular therapy. So primary endpoint of the Basel 2 was amputation-free survival, which was similar to that of the best CLTI trial, Basel 1 trial. So number 3 is who did EVT. So in the best CLI trial, 75% of the endovascular procedure was done by vascular surgeon, while the 84% was done by IR in the Basel 2 trial. So number 4 is a conclusion. Best CLI demonstrated the bypass first strategy was significantly associated with decreased risk of the event, but the Basel 2 demonstrated the bypass first strategy was significantly associated with the increasing risk of the event. So finally, outcome mainly driven by the few major amputation and reintervention in the best CLI bypass first group, while the few deaths in the Basel 2 best EVT first group. I think Basel 2 recruit the patient who required the infrapopulatory revascularization, and the average age was 82 years, which is very similar to Asian population. So 2 months ago, I attended the annual meeting in the Japanese Society of Cardiovascular Surgery and met both first authors. Dr. Farber mentioned that they are working hard on the 60 sub-analysis using the best CLI trial database. In contrast, Dr. Bradbury says that the important thing the CLI treatment is patient education and early diagnosis, early intervention. So I enjoyed very much a conversation with the 2 authors. So based on the talking to them closely, I think the next, as mentioned in the discussion of the Basel II trial, better prevention and the timely referral to secondary care earlier. So although we have learned a lot from the two studies, there is a substantial gap between the evidence and the practice about the CLTI population. As shown in this slide, octogenarian, low BMI dialysis, and the reduced cardiac function are very common in our daily practice. In this kind of patient, their arterial disease is shown in this right movie. This is a representative anatomical feature we fight against every day. So before revascularization, we routinely conducted a calculation of the 2-year mortality risk, SVG evaluation, Woong-Su stratified the Wi-Fi classification, anatomical severity classified the glass stage in my practice. So in our daily practice, many patients do not have the suitable saphenous vein graft for bypass surgery, so they are deemed only suitable for endovascular therapy. And even patients who are deemed suitable for vein bypass had a good vein might choose the less invasive endovascular option. So based on this situation, so my interesting is how many CLTI patients are eligible for best CLI cohort 1 in Japanese real-world practice. So when we take a look at the inclusion and exclusion criteria of the best CLI trial, I feel that more than half Japanese, perhaps the Asian CLTI patients don't correspond to these criteria. Main driving criteria for the determination of the bypass therapy indication is the mortality risk, anatomical severity, and the presence of a usable vein. So according to the GVG, standard surgical risk was defined as estimated less than 5% perioperative and less than 50% 2-year mortality. And these can be calculated by our Spinach score. In a study population, that 87.5% of the population fits a standard surgical risk. Arterial lesion characteristics evaluated by DSA were able to classify the glass IM modifier. P0 and P1 were defined as an adequate target of tibial artery for this anastomosis of the surgical bypass therapy. Based on this, my understanding, in a study population, 76.1% of the population had a P0, P1 glass IM classification, fitting the distal target of the bypass therapy. So finally, so when good quality of the great saphenous vein is defined as a diameter larger than 3 millimeter, 46.3% of patients had an appropriate quality of the saphenous vein graft. We finally conducted a calculation of the patient who met all 3 criteria. As shown in this slide, in Japanese CLTI patient, only 1/3, 33% of CLTI correspond to the best CLTI cohort 1 criteria. So how about this clinical scenario? If the patient has the standard surgical risk, adequate distal target of the bypass therapy, and a good quality of the saphenous vein graft, should we consider the bypass first strategy for CLTI patient? But I think the anatomy fits the endo. How can we treat this type A CLTI patient? Bypass first or endo first? So I cannot answer right now appropriately because this kind of patient is generally treated with the endo first in clinical setting. We should fairly understand that, as mentioned in the GVG, revascularization strategy should be determined by Wi-Fi and the glass stage. So we additionally investigate the proportion of the GVG-based bypass preferred condition based on the glass and the Wi-Fi system in our practice, in our previous database. So in this analysis, only 27% of these patients correspond to the GVG-based bypass preferred condition. So in summary, in Japanese CLTI practice, when we subtract the population with perioperative and 2-year mortality risk, IM no bypass surrogate and the poor quality of the SVG from the overall population. And we identified that GVG-based bypass preferred condition based on the GLASS 3 and the Wi-Fi 3 or 4. Only 8.9% patients should be treated with the bypass first strategy, which represents a relevant gap between the evidence from the best CLI and experience from the real-world practice. So another, my perspective is that endovascular and the surgical is not competitor, but the complementary relationship in the clinical practice. So we need more discussion about the next GVG, best CLI, and the Basel II trial. Thank you for your kind attention.
Very good. If you want to go back to room 1 just to see where they are, and maybe we can get a final picture and then we can do the final talk.
Okay.
Dr. Yoon, we're back with you.
Yes, thank you for coming back. As I told you, I inflated the balloon with 8mm balloon. And then the patient feels some pain at his lumbar area, back area. So I just stopped the balloon at 4 ATM. And then this is angiography just after the balloon angioplasty. You can find there is a plaque and then dissection. And I was not sure the distal reentry space is below the bifurcation area. So the lesion length is just 3 centimeters. But if the dissection is propagated to the external iliac artery, if I short stenting, I can maybe progress the dissection deeply. So maybe I can insert more stent in external iliac artery. So I selected 60mm balloon expander stent Dr. Jae-Hwan Lee suggested. And then this is stent placement. And then you can find the external iliac ostium is covered by this stent. And then this is the stenting moment. And then this is angiography just after stenting. Fortunately, the internal iliac artery is safe. And then the external iliac artery is also safe. So I'm very satisfied at this angiography. But you can find there is a residual stenosis at common iliac artery, smaller than the external iliac artery. So now I inserted the balloon, 8mm balloon again. And then I will perform adjunctive balloon here until the patient feels severe pain. 환자분 허리 또 아프면 얘기하세요. 또 아프실 거예요. As you can hear, I can talk to the patient during balloon implantation, check whether he feels pain or not. 괜찮으세요? 네? 참을만해요. 4 ATM. Nominal? 6 ATM is nominal pressure of 8mm balloon. So the vessel is over 10mm, so I don't think the vessel ruptured using this 8mm balloon. So I touch the nominal pressure here. Safe. And well dilated. Deflation. Do you think we need more bigger adjunctive balloon application in this patient?
No,
No.
I think at the end of the day, it's perfusion and pressure, and it's going to help their leg out a tremendous amount. Then if it fails by restenosis, you have a whole myriad of things you can deal with. But right now, you've got what you need, which is flow again.
Okay.
I suspect that this will work very nicely for the patient.
I hope so.
I'm pretty sure.
Okay.
We have to go to our final talk.
Can we get one last angiogram here before
One
we
angio,
go?
please.
숨 참으세요.
Nice.
That turned out lovely.
아래요.
for how easy that thing started out looking to where we are. That's a testimony. Congratulations.
Okay, there's no complication. It seems good. Okay, thank you for your attention, and then your comment was very helpful to me, and then make this procedure successful. Thank you.
Thank you for persisting. Really nice case.
Very nice case. Excellent. We have a recorded lecture from Thilo Kolbel, the role of air-embolism in cardiovascular interventions and how to prevent it.
Ladies and gentlemen, it's my great pleasure to present at this TCTAP meeting in Seoul a presentation on air-embolism, its role in cardiovascular intervention and how to prevent it. I regret very much not to be present at this conference and hope to see you all soon at another meeting. So why is air-embolism such a big deal in cardiovascular interventions? I would like to give you the conclusion at the beginning. The reason is that stroke is the biggest unmet clinical need in TEVAR and in TAVR. Air-embolism is a proven cause of stroke and cerebral damage. And TEVAR and TAVR devices release significant volumes of air in sensitive segments of the cardiovascular system. The air bubbles are introduced by the delivery systems of the devices, and it can be easily reduced by the use of carbon dioxide flushing. So if we take a look at these major cardiovascular interventions, they are all plagued by one complication, which is stroke. And here, physicians and patients are of the same opinion, as you see here at an audience poll at Link 2020. What is the biggest unmet need in thoracic endografting? It is stroke reduction with a vast majority. If you look at an audience poll at the ACC about what patients are most concerned when they consider TAVR, it is stroke. So this is the area where we need to focus more of our efforts on in the future, how to avoid stroke. If we look at TAVR devices of the first generation and of current devices, the risk of stroke has not significantly reduced. It's gone from 4 to 3%. This may just be due to learning curve and reduced manipulation in the aortic arch in those cases. The strokes happen very closely to the procedure, usually within 3 days, as you can see here, and they are associated with a high post-TAVR mortality and a change in the destination of the discharge. What is also very interesting is if we look at mortality and bleeding complications, there's a continuous reduction of those significant complications and negative outcomes, which is continuously decreasing with an increasing procedure number. If we look at stroke, it is something that seems to be unaffected by the number of procedures after a certain learning curve has been reached. So this curve is not going further down as the others. If we look at stroke and cerebral damage, the stroke rate, whether it's 1, 2, 5, or 20%, depends mostly on the definition which is used in the study. So if we use VARC2 study, we almost have a guaranteed low stroke rate. But if we see at the more subtle cerebral damages that are done during these procedures, then it's more about 50 or 90% of patients that have a damage. These silent brain infarctions, which are shown on DW MRI imaging, they are not so silent. They are associated with a long list of negative neurological outcomes ranking from postoperative confusion to dementia and future stroke. In TEVAR, there has been ongoing new studies looking at the differentiation of gas and solid. and has been shown that on TCD, the vast majority of embolic signals traveling through the mid-cerebral artery are of gaseous origin. And those Air-Embolisms are associated with a number of DWMRI lesions. There are basically two pathways of air-embolism in cardiovascular interventions. One is through the sheath, and one is through the devices, which you see here. This is what we want to talk about mainly today. Here you see an earlier TAVR device, and what you should notice on the TCD is when the most proximal part of the sheath is withdrawn, it starts without any interaction between the new valve and the native tissue. You can see that massively hits are starting on the TCD measurement, although there has not been interaction which may have dislodged any solid material. So this is a proof that there's something released from the delivery system which causes embolism to the brain. If we look at studies reporting hits during TAVR implantation, it's always been surprising to me that during valvuloplasty there are not many hits on TCD, and most of the hits are recorded during positioning and implantation. These are the parts in which the devices are opened in the aortic valve. It is the same during TEVAR. The hits happen during the deployment phase of the device, which has been shown in a number of studies. The pathophysiology of air-embolism is very clear. It has been studied for many years, and even the smallest bubbles of 5 micron diameter, they can cause significant damage ranging from metabolism issues, blood-brain barrier damage, etc. Here you see what a 40 micron bubble, which is not visible, looks in a human capillary. This has been understood very well in cardiac surgery many years ago, when the so-called bubble traps were introduced in the cardiopulmonary bypass machines, filtering out the small air emboli from the machine, and has been associated with a significant decrease in confusion and neurocognitive problems after surgery. There also have been neuroradiological studies showing that the damage is higher when no air filter is used. Some new studies looked at these very small bubbles below the visible size, showing that if released in the ascending aorta, bilateral damage is seen on DW-MRI, and when released into carotids, only unilateral damage is seen. This study looked further, and beside a negative control when released in the atrium, it showed that there's a nonlinear, volume-dependent relationship between number of air bubbles released and damage in the brain. The prevention method that is available today is mainly carbon dioxide flushings, and this is what we have been using for some years in our TEVA devices by hooking up the TEVA device to a carbon dioxide bottle. It is something that doesn't take very long, and it makes sure that of the air present in the device, more is exchanged for carbon dioxide, which is far less dangerous for the brain compared to room air. And you see that doesn't take long, and it's extremely important to do saline flushing afterwards as well. It has been described to be an important part of a cardiovascular operating room outfit, and it has been shown in studies that when devices are carbon dioxide flushed, then the number of lesions in the brain is significantly reduced. This is just a study that our group has been part of, where we could reduce the number of lesions depending on a number of factors. Air is also an issue even when devices are loaded under water. You can see that there are still air bubbles released. There has been a recent RCT looking at carbon dioxide flushing in TAVR, showing a lower number of lesions when devices are flushed with carbon dioxide. Let me conclude. Stroke is the biggest unmet clinical need in TAVR and in TAVR. Air embolism is a proven cause of stroke and cerebral damage. TAVR and TAVR devices release significant volumes of air in sensitive segments of the cardiovascular system. Air bubbles are introduced by the delivery system of the devices, and air embolization can be easily reduced by carbon dioxide flushing. Thank you very much for your attention.
Well, thank you very much for that interesting presentation. Well, that concludes this session. Would very much like to thank the live case operators for two really interesting and challenging cases, and thank the panel for their excellent commentary. I think we all learned a lot together today. So thank you very much.